Hello, everyone. This is your host, Dr. Maxwell Cooper, and I'm very excited to bring you this very special episode of the DaVinci Hour podcast that I actually co-produced with my guest, Dr. Jack Kartush. Dr. Kartush is a world-renowned surgeon, medical device inventor, and entrepreneur who is a pioneer in the field of intraoperative nerve monitoring, which we will discuss during this episode among his many other accomplishments during his illustrious career. Dr. Kartush provided a series of graphics and images to complement our discussion, which are displayed throughout the video. So those of you who are listening to this episode may actually want to watch it on YouTube, and you can find it by looking at the link in the description for the episode. And so without further ado, here is my discussion with Dr. Jack Kartush. Hey, everybody, welcome back to the DaVinci Hour podcast. I'm very honored to be joined by Dr. Jack Kartush. He is a neurotologic surgeon, a serial medical device inventor, an author, and an academician. He really is a pioneer in the field of intraoperative neurophysiologic monitoring. He was the founding president of the American Society of Neurophysiologic Monitoring, and he's also been the principal developer of the most commonly used facial nerve monitoring device, which is actually now produced and distributed by Medtronic. He's also been a pioneer in many other aspects of medicine and surgery, including patient safety, long before the World Health Organization or the Joint Commission. He was the first to recommend that surgeons actually mark the operative site. So when you go in and have your site marked before the surgery to make sure they're operating on the right side, you can thank Dr. Kartush for that. And then really the early developments of the checklist in the operating room before proceeding, our safety checklist. Lastly, he's the co-founder and the director of the Michigan Ear Institute. And then he's also published nearly 200 medical publications and has over a dozen patents. So, Dr. Kartush, really excited to get into your very interesting and diverse set of experiences, and happy to have you on the podcast. Thank you for joining us.
Thank you, Maxwell. Glad to be here.
All right, so Dr. Kartush, why don't we start out, in our earlier conversations, you told me about how you were someone who had this kind of urge to invent or urge to change things for the better at a very early age. Why don't you talk about kind of your early days of inventing, if you will, and give us some insight into, kind of how you, developed into the inventor you are today.
Well, started out as a kid, and my big mantra was, well, what if? What if we did things a little bit different? Could it be better? Could it just be unique? And sometimes as a child, that led to good, and not infrequently, it led to harm. So at one time, I picked up a uranium core from a museum. It was spent, of course, but I was savvy about comic books, and I knew that uranium and radioactive materials sometimes could be recharged with lightning and electricity. So I took copper wire, wrapped this uranium core, plugged it into an AC outlet, and after sparks, smoke, singed fingers, and every fuse going out in the house, my parents were very reluctant for me to try some of these things. I was always late for dinner because I loved reading. And my father one time said, Jack, your food is always cold. You're going to eat it whether it's cold or not. So I looked in the toaster and I noticed these orange glowing wires. And I said, Dad, what if we take orange wires and put them underneath the plate? And even my dad thought, maybe this is not a bad idea. So, not having bucks, not having any idea about patent technology, I, of course, did the proper thing, which was to go to the drugstore, get Popular Mechanics magazine, and I looked up the classified ads. And we found a bunch of ads that said if we sent them $50 and drawings of our patent, they could assuredly get us millions and fame. And this sounded like a good idea to us. But $50 in 1960 was a lot of pesos. So I did convince my dad, and we got a package of things to describe our idea of heating wires in a plate, drew out the pictures, send it to this company, and at no time do we ever hear back from them. We would send them letters, nothing. So a year and a half later, The first hot plates came out on the market. Coincidence? We didn't think so. But really, we didn't have any recourse. So it was a sad ending, but it really taught us a valuable lesson. I had no idea about going into medicine, but at age 12, I saw the Beatles on Ed Sullivan. And for people of my vintage, it was a life-changing event. Here's these long-haired guys playing exciting music. We convinced my mom to take us to see the Beatles in Detroit in 1964. The music was phenomenal. The girls were ecstatic and screaming, passing out. There may have been other hormonal things happening to them at the time. I did not understand it at age 12, but unequivocally I said, this is the career for me. I got a used guitar. I taught myself how to play, started a band, and then I realized that most boy bands just copied other people's music. So you'd pick up the Beatles or the Beach Boys. And I said, you know what? I think I can write songs. So I wrote a whole bunch of songs. So we started getting gigs. And I said, we need to distinguish ourselves from the other Beatles wannabes.
Sure. Quick question, Dr. Kartush.
Yes, sir.
Who did you who were your bandmates? Like, were these just friends of yours, or I guess how did you put the band together? I'm curious.
Yeah, just a bunch of buddies that were like-minded and that were interested in doing original music. And it was a real problem because if you wanted to get a gig, people wanted to hear cover tunes. They wanted to hear things that were already on the radio. So it was really hard to get original music played unless you were already somebody. You couldn't be somebody unless you established. So it was a catch-22. So I said, all right, let's distinguish ourselves from the wannabes. So we had original music, and everybody knew about Jimi Hendrix in 1970. But around 1967, he tried putting some lighter fluid on his guitar, and people don't know about this, but the first time he did it, he got second-degree burns on his fingers, and he had to quit the gig. I liked what Jimmy was doing, but I wasn't willing to endanger my Gibson Les Paul Special. So, of course, I convinced the drummer. So we had a big gig, and I said, look, Larry, I'm going to put lighter fluid on all your cymbals. We're going to do this new crazy song. We're going to have the lights come down, and I'm going to ignite the lighter fluid. Sounds cool, dude. The crowd went crazy. The drum set is on fire, but the drummer became so excited that he bashed the cymbals on fire. They rolled out into the audience. So the audience went from being excited to being manic, and people were running out of the door, getting away from the spinning cymbals on fire. Suffice it to say, the fire marshal came in. We were never asked to come back to the gig, but we just did this thing once. And by coincidence, Decca Records from London, England, happened to come in and hear us for our next gig. They saw this psychedelic music with drums on fire. The guy comes up and says, oh, you blokes are quite good. I'd like to offer you a recording contract. And of course, we thought it was just bullshit. And in reality, he was from Decca Records. So we could not believe it. 17 years old, we're getting a recording contract. It's everything we ever wished for.
That's wild.
But he digs into his luggage and he says, no, you're quite correct that you need to have something to distinguish yourselves from the Beatles want to be. So he pulls out from his luggage container these frilly, iridescent costumes that had a big eye on the front. You will be called the Iridium 5. We will establish some dance moves. Now, being sophisticated 17-year-olds, we said, there's no freaking way we're going to do this. And for right or wrong, we turned down Decca Records for a recording contract when we were 17. The interesting part is the Decca A&R man, acoustic and repertoire man, went back to London, and he found a man named David Jones, who had no compunction about wearing frilly costumes and coming up with dance moves. And David Jones changed his name to David Bowie. So the long and short of it is, we turned down Decca Records. David Bowie picked up on it.
That's an amazing story. I mean, it's so many things there. I mean, just that one that you guys had that opportunity presented to you, and then here you're just some kids, trying to have some fun and be different, and then you catch the eye of this, recording artist who clearly had an eye. I mean, if he picked David Bowie, he clearly had a good eye for finding talent. So that's, I think things ended up working out okay for you, but I imagine if you took that, your life would have had a very different trajectory.
Yeah, you really never can tell. And of course, so many people that are offered recording contracts don't make it. So, right around this time, I decided the statistical probability of making it as a rock star would be less than medical school. I had no desire to go to med school, but when I was in study hall one day, I was hearing two guys saying, "Come on, Jamie, we got to try hard." Well, no one's going to get into med school. It's so hard. But look, if you do, you'll be well respected. You'll make a good living. You'll be able to get a motorcycle and a house. And I go, okay. So I applied for medical school, got in. I never gave up on music, though. So right around the same time, Maxwell, synthesizers were being produced. And at first they sounded really weird, but they got better and better. So I didn't know how to play keyboard. I taught myself how to play keyboards. There were MIDI synthesizers that allow you to play the left hand first and then the right hand, and you could play the horn and the bass and the trombone. And so I built up pieces. So being at University of Michigan, I made a connection. And if you've ever heard of the big house at University of Michigan,
Oh, of course. I've been there.
have you?
Yeah.
So believe it or not, they played my synthesized version of Hail to the Victors in front of 100,000 fans,
Wow.
and the crowd went crazy.
That's amazing.
From there, somebody from Fox TV said, "Hey, who's this guy that can do some of the stuff in his bedroom?" So Fox TV was interested in updating the sound of their soundtracks from the opening credits from the 10 o'clock news. So here I needed to have something that didn't sound synthetic. So I had the sound of trombones and timpani drums, etc. And I wrote the Fox TV 10 o'clock opening news for Lexington, Kentucky. And if you're interested, I just put up a version of it on my YouTube channel. If you just go to YouTube and put in Kartush, you can see a bunch of things. Then Fox said, "This is fantastic. We'd like you to update all the Fox TV affiliates." And I go, I've got a lecture in Korea. They go, "What do you mean?" Well, I'm not a musician. So I gave up the job of doing soundtracks for TV.
You had this keen interest in inventing from an early age. Were you an engineering major, or did you consider doing engineering versus medicine at all? I'm just curious.
I loved engineering and I had no background in it whatsoever. I never felt any hesitation to say, all right, these 10 things didn't work. What if I dig just a little harder than someone else and maybe find something that is there?
Interesting. And I'm curious, your decision to go to medical school, did you have, I guess, the vision or the aspiration to not only become a physician, but become a physician inventor, be someone who developed new innovations and new devices, in addition to just being a practicing physician?
I always had this creative bug since I was a kid, and sometimes it would lead me into trouble. But I remember hearing early on from one of the surgeons I was working with when I suggested something. He says, "Jack, the enemy of good is better. This is how we do it. It's been working for so many years. Don't rock the boat." So this brings me into med school. I'm a third-year student on anesthesia, and I watch the anesthesia intern intubate a patient for general anesthesia. He intubates the patient, and everything seems to be okay. And about 2 minutes later, the heart rate and blood pressure start going crazy. And all of a sudden, people go, hey, something's wrong. They call a code. People rush into the room and they realize that the anesthesia intern intubated not the trachea, but the esophagus. So they realized that the patient was asphyxiating and dying right before our eyes. They call a code, they extubate the patient, they reintubate the patient, and they save the patient's life. Of the people that came in for the code, one was the chairman of anesthesia of University of Michigan. And I said, Doctor, I notice that changes in heart rate and blood pressure are late signs of hypoxia. And then my classic is, what if we start measuring oxygen and CO2? He put his hand on my shoulder. He says, Jack, we don't need gimmicks in clinical medicine. Just know what you're supposed to do. For right or wrong, I listened to the wisdom of the chair. 2.5 years later, the very first pulse ox came out of Japan. And it was crude and it didn't always work well. And I just kicked myself saying, why did I listen to him?
Yeah, I feel like you hear those kind of stories so often in medicine where that, a young, because as a student, you see things, fresh. You don't have the biases of, you know, obviously years and years of experience has its advantages, but you also have the disadvantage of possibly becoming jaded, or, pigeonholed in what you're doing. And then I feel like you hear these stories so often where a young student or physician comes up with an idea and it's immediately shot down. So, and
Absolutely. So I did listen to the expert. I didn't follow it through. And when I saw the pulse oxes come out and completely change the world of assessing hypoxia, oxygenation, and later CO2, I just said, why did I listen? 12 months later, I'm a fourth year medical student. I decided I wanted to go into neurosurgery. And being a cocky kid, I said, what's the best place in the world for neurosurgery? They said, Karolinska Sjukhuset in Stockholm, Sweden. I said, I want to go there. So I took a half a year and I went to Stockholm and studied in my fourth year of medical school. My first month was on neurology. So I learned needle electromyography by the top person, Professor Kuckelberg, in the world. And my second month was working with the top neurosurgeons in the world. And one of the interesting procedures was the removal of acoustic neuromas and meningiomas. These are benign tumors that grow between the brain and the inner ear, and they always stick on the facial nerve. Not only are they sticky, but sometimes they push the facial nerve out of location. So when you expect the nerve here, it's pushed here, and it's down to a diaphanous sheet that you can barely see. So I suggested, what if we try to do some monitoring? And he says, anatomy is what you need to know. I went back to the chief of neurology, and for breakfast, I wrote on a napkin a picture of a box with an oscilloscope, a loudspeaker, and some stimulators. And it's probably before your time, Maxwell, but there was a game called Operation.
Sure. I've played it. Yeah.
And the interesting thing was that you had electrified tweezers. You had to take out the kidney, but if you got too close to the edge, it would beep and it would warn you that you failed. Now, when I learned electromyography, I understood stimulation would help detect the nerve, and the closer you are. So my epiphany was a small box for EMG in the operating room with stimulating instruments that would act like a minesweeper. If you got near the nerve, you'd get a beep. If you didn't get near the nerve, you wouldn't get a beep. And the old game that kids would play, am I hot? Am I cold? The chairman of neurology said, Jack, that is genius. I took it to the chief of neurosurgery, and he said, Jack, we don't need gimmicks. We just need to understand anatomy. So he said almost the same thing that the anesthesiologist, but he said it in Swedish. So I left Svenska. I flew back to University of Michigan. I tried to convince the neurosurgeons and the otologists. Nada. I said, you know what? I'm going to patent this on my own. People said, you are an employee of the University of Michigan. You better go talk to the patent lawyers. I went in, they made me sign forms saying that University of Michigan gets the first 10 million. That's okay. I just wanted to get it done. Month after month after month, I'd go back and say, how's the patent going? Well, we're still doing due diligence. So after 9 months, I said, where's the patent? Well, we've surveyed the market and we know there is no interest in monitoring nerves during surgery. I just said, you're nuts. So I looked up the names of companies that made EMG, electromyographs. I found one in Madison, Wisconsin called Nicolay. They thought it was a great idea. They said, look, we already have an EMG, and if we hook on your stimulators and put in some smart technology, this could be great. Sign here. I said, well, I'm still an employee at University of Michigan. I don't know if I can sign. Now, in retrospect, it may have been the wrong decision, but that's what I told them. Surprisingly, and it took me a couple of years before I left Michigan, they held true. And when I left Michigan, they went ahead and gave me royalties, consulting. They worked like crazy to make this fantastic machine with all this built-in new circuitry. Just before it went to market, the vice president of sales said, we'd like to get the feedback of experienced surgeons. So sounds like a good idea. Just make sure to get an NDA, a non-disclosure form. So they went to a couple centers, but then they went to one of the most famous centers in the world for acoustic tumors. And one of the surgeons said, I love this thing. Put my name on it and I'll sell a ton of them for you because I've trained all these people. Well, the company said, well, no, Kartush invented it. And we're not even going to put his name on it. We're just going to call it the Nerve Integrity Monitor, the NIM. Because they didn't have him sign an NDA, he took my idea, went to another company, and had them clone it.
Wow.
Shot ourselves in the foot. And it didn't even come out for a while.
Now, I'm sorry, had you filed the patent in your name at this point or no? And
thank you for asking.
Yeah, go ahead.
Thank you for asking. So I was still concerned that, I couldn't file a patent since I was still a U of M employee. Now, for the 100 patent attorneys I've ever talked since then, they said I was a fool. Because once U of M attorneys said, we don't think there's a market for it, I should have considered it as right of first refusal and then taken it on my own. I didn't. And of course, I had no knowledge. I had no money. And you work hard nowadays. But in 1978, 1979, as a surgical resident, I worked in-house every second and third night. So between lack of knowledge, lack of money, and lack of sleep. So I didn't try to get my own patent. I went to Nicolay, and unbelievable, they started work on the NIM monitor, and they didn't get a patent. I go, Jesus, what's going on? We think if we're first to market, we'll capture it. It'll be like the Frisbee. The first Frisbee got out there, and nobody could catch up to it. I go, I don't know. So not only was that a mistake, but again, by not having a patent, it allowed this other surgeon to come up with a clone and absolutely kill the market for the first 2 years. I'd like to say, every cloud has a silver lining. And so just even like when my first patent as a kid failed, I learned to be careful about patents. So I did get a lesson. So Nicolay Company said, Kartush, you said that this was going to be a home run. We're not selling anything. We've put $1 zillion into this. I went to the president of a little dinky ENT company called Xomed, Xomed. And I said, remember I talked to you about getting involved in nerve monitoring? He said, yeah, we don't know anything about electrophysiology. I said, the device is built. The company wants out. You could buy it on the cheap. I guarantee you that once the other device fails, this is going to be a home run. He bought it.
Wow.
Couldn't believe it. And we set up consulting, we set up so and so. Now, it took a while because first the surgeons, even with the machine there, were very reluctant. But it did better and better and better. And the stinky little company, in addition to doing some other things, they started working on Zomed debris or sinus debriders. But the main thing is this medical electronic device. Well, what's the biggest medical electronic device company in the world?
Medtronic.
Medtronic. So now that the stinky ENT company that took care of mostly tonsils and tubes had this fabulous medical electronic device, they bought not only the NIM technology, but they bought out the whole company.
Wow.
So it did very well for the people at Zomed. And I was actually happy because as soon as I had the Zomed monitor for facial nerve, I wanted to take it to the next level. Monitor brain, monitor spine. And it was very difficult. And Medtronic said, well, we don't know. And then Medtronic spent zillions of dollars to buy Sophomore Danek, one of the biggest spine companies. And then they came out with the Medtronic spine. I go, well, that's my device. Great, let's work on it together. No, it's really a completely different device. I go on the Medtronic website and it said, the Medtronic spine, based on years of work from the Medtronic ENT device. So nothing always works out well. So I've had some home runs and I've had a lot of outs.
So this device that this is for, just so people understand, is for essentially monitoring injuring the nerve or spinal cord during spinal surgery, correct? Which is obviously a daily, I'm sure there's operating rooms right now using it in spine
Every
surgery.
day in most operating rooms in the world. So for the facial nerve, first surgeons kept on saying, no, it's a gimmick. I'm not going to use it. And especially for low risk cases, it's just like pulse oximetry. If I put pulse ox on your daughter for a tonsillectomy and adenoidectomy, chances are her oxygen level is going to be good. And at the end of the case, you probably would have done just as well with and without a pulse ox. It's just that one odd case. When I started pushing it for neurosurgeons and otologists, taking out the acoustic neuromas, meningiomas, and glomus jugulare tumors, where the nerves are stuck like crazy, all of a sudden it's like, hallelujah. I love this thing. And people are saying, well, does it really work? Let's do a double-blind study. My friend Steve Harner from Mayo Clinic said, I will never do another acoustic neuroma without Kartush's facial monitor. People said, well, let's do a double-blind study. And he said, it is so obvious how much safer it is to use a nerve monitor and know where the nerve is and know when it's getting injured, that if I did a double-blind study, it would mean half of my patients got a monitor and the other half didn't. And I feel it's unethical keeping it away from that other half.
That's amazing. I mean, essentially that ushered in, becoming the standard of care, which is pretty amazing. And I guess the application, just so the listeners understand, I guess a little bit more, just because this is incredibly complex anatomy. I mean, obviously you're, a world expert in it, but this is, you're removing these tumors near where the nerves that innervate the facial muscles and obviously give you the cranial nerve 8, which does the hearing, and, vestibular function. I guess to give people an idea, I guess, what's the consequence if they don't use this and they do injure the nerve? And I guess to give people an idea how
totally paralyzed face. So it looks like a stroke.
Mm-hmm.
And if the nerve is just bruised, it may slowly come back. If it's transected, it'll usually never come back. Sometimes you try to sew in a graft. And it's not as bad as being quadriplegic, but the fact that now your eye is exposed, you're drooling, and everybody thinks you're a sad sack, it is a huge psychiatric impact. In fact, I'm not sure if this point would be a good time to show my 3-minute video on nerve monitoring when I first was interviewed by ABC TV to show the lay public how it works.
Okay, so here is a video clip from a TV report in 1988 in which the reporter did a very good job, I think, of describing the issues involved.
Doris, this is an instrument that could make a number of delicate operations much easier for the surgeon and far less risky for the patient. Right now it's being used primarily to help doctors remove a common type of brain tumor. No, that familiar sound is not signaling a doctor to call his office. Rather, it's warning a surgeon that he's in danger of injuring a critical nerve in his patient's brain. The device is making surgery much safer for people like David Wojciechowski. A non-cancerous tumor growing inside his inner ear. It was on his right side and had already begun to press on his brain. The technical name for it is acoustic neuroma. The tumor was actually taking root and growing around 3 vital nerves that affected David's face, balance, and hearing. Removing the tumor could cause irreparable damage to one or all 3.
Depending upon the involvement of tumor to the facial nerve can be varying degrees of injury to the nerve. The goal of the surgeon to try and reduce the amount of injury while peeling the tumor away.
Here's what can happen if the facial nerve is damaged. Muscles in the eye and face become paralyzed. Speech and swallowing are difficult, and there's a risk of blindness. That's what this revolutionary new device was designed to prevent. Before surgery, tiny needle electrodes are placed into facial muscles in several spots. These in turn are connected to the monitor, which is actually a mini computer. Whenever the surgeon touches, pushes, or pulls on the facial nerve, the monitor begins to sound an alarm. When this happens, the surgeon knows to proceed more cautiously or move on to other parts of the tumor. Dr. Jack Kartush of the Michigan Ear Institute is one of the co-developers of this early warning device. Using the new monitor, Dr. Kartush was able to remove the tumor from David Wojciechowski's inner ear without injury to his facial nerve.
None of these devices that are just being developed are perfect, but devices like this do help reduce the risk of facial nerve paralysis.
It's believed that this new monitoring technique can be adapted for use in a wide variety of operations, and in the future it may play a significant role in reducing the risks of surgery to the thyroid, heart, and spinal cord.
Okay, so now let's talk a little bit about these stimulating instruments that are part and parcel of the system of monitoring.
And like a minesweeper, move towards it, hear beep, 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 then back up. It went from being derided to being accepted. Well, now all of a sudden everyone's using it. It's essentially becoming a standard of care. But at no time did the manufacturers say, well, if you're going to use this new device, you should take a training course. And you may be aware that if you start using DaVinci robots now, you can't do so the first day in the operating room. You take a course. The first time we started doing endoscopic sinus surgery, you had to do cadaver studies. But at no time were doctors required in taking a course on nerve monitoring. So reluctantly, when monitoring was set up correctly, it worked poorly. And my dictum was always, poor monitoring is worse than no monitoring. It's like a minesweeper that's broken, and now you think it's working. You walk right towards a mine, you don't get a beep, and you now go ahead cavalierly and keep going. So when it's not functioning correctly, if you're not knowing how to use it correctly, don't even use it. So then the next part of my career was, how do I fix the lack of education for using monitoring correctly? It's not just plug it in and assume that it's going to give you all the answers. So I had one of the busiest neurologic practices in the world. I was writing my 1 to 200 publications. I was lecturing around the world teaching about it. But in the spare time, I decided I would write the first textbook on intraoperative neurophysiologic monitoring. Then at night, I started working on developing the first medical society on intraoperative monitoring called the American Society of Neurophysiologic Monitoring, and it's now the largest society of this type in the world. And all these things help make it safer.
Well, by the 1990s, spine monitoring was becoming so desirable that surgeons came to us to say, can you help us train technologists? And how do we find technologists for a field that hadn't really existed before? So we started training audiologists, kinesiologists, wannabe pre-med students, and this actually turned into an entire new industry. So we responded by becoming entrepreneurs, and my partners at Michigan Ear Institute and I started American Neural Monitoring, which was then bought out by Biotronic Monitoring in Ann Arbor to become the largest monitoring company in the world. And it was then bought out itself by NuVasive Spine Company in San Diego for $100 million. So in our so-called free time, we became accidental entrepreneurs.
As you probably heard, what is the real value in expert opinion when it comes to the future? They might be very good at saying, here's how to ligate, here's how to put it in your balloon catheter, but do they really know the right way to deal with pulse oximetry and nerve monitoring in the future? At the time of COVID, you may have heard of Dr. Semmelweis. Dr. Semmelweis, 100 or 200 years ago, found the following. The obstetricians had a high rate of infant mortality and maternal death, but he noticed that the midwives had much less death. And the only thing he could find is that the midwives washed their hands. So he went on this evangelistic path to say, you need to start washing your hands. Now, you may recall that 200 years ago, surgeons wore white smocks, filthy with blood and guts. They didn't change it. Do you know why?
No, I'm actually not sure.
Because it was a sign of experience. If you were the new kid on the block with a white smock, clearly you don't have experience in surgery. But if you were filled with filth, this is a guy that knows his stuff. So Semmelweis's colleagues harassed him, derided him. He became depressed and eventually was incarcerated in an insane asylum. Ironically, the insane asylum was filthy, there was no hand washing, and he died of sepsis in the insane asylum.
That's unbelievable. Wow.
Things change, but this is the skepticism involved in medicine. So at that time, because I was being harassed so much by people initially, I remember liking the Beatles. So remember we talked about that. Did you know that in 1962, remember the Beatles came to Detroit in 64, but in 1962, they interviewed at Decca Records, which was one of the biggest record companies in the world. They said, we don't like their hair. We think guitar music is going out, and we're not going to sign a contract. So the funny, ironic thing is, they became an embarrassment in the recording industry. And the only reason that my band even had a demo was because they said, it's time to find new rock bands. So they sent an A&R man, acoustic and repertoire man from Decca Records to America to find rock bands. So by turning down the Beatles, it gave us a chance. We turned them down, and then they found David Bowie. So how good was the value of Decca Records in anticipating the future? Not good. And here's my last little anecdote, and hopefully I'm entertaining you. Is one of my favorite movies used to be It's a Wonderful Life. Remember that one with Jimmy Stewart?
Sure, of course.
It was directed by Capra, who thought it was the worst movie he ever made. The writers were quitting. People were fighting all the time. Jimmy Stewart came back from the war with post-traumatic stress syndrome. They thought the movie was terrible. The first reviews by the newspapers said it was sappy, overly sentimental, and not worth your time. It was so bad that instead of continuing to pay the ongoing copyright protection, Capra stopped paying copyright protection. So remember how I always talk about silver lining in clouds? Because there was no copyright protection, all the new cable TV said, we can play it for free. It then became the most beloved Christmas classic ever, and only because it was considered bad.
It's unbelievable.
So whether it comes to movies, videos, rock and roll, I learned that there's a lot to be said for experts, but not when it is said for what you are predicting the future for.
Dr. Kartush, as a follow-up to that, because this is something as a, early in my medical career, I think about is when you encounter those situations, and you don't necessarily have to be early in your career. You could be even experienced and encounter that kind of criticism or discouragement, if you will. I guess how do you deal with that? What's your advice on that? I'm just curious, like what would I guess, and also like how do you know that point of where maybe they're right, maybe I shouldn't do this, or that point of where, you know what, maybe this is actually, I should just ignore that and continue, pursuing this.
Goal number one is your personality. So you have to have creativity, but you have to have resilience. You're going to get knocked down repeatedly. And you have to have some feeling that I don't mind work. Before the internet, I was in the library Xeroxing all the time, and that was a lot of work. But every time I found an article that led me along my path, I got the squirt of dopamine and endorphin and was going, yes, that's good. It's not the whole enchilada, but if you can get reward along the way, it'll tell you don't stop. The secret to happiness is enjoying your work. And then I started reading a little bit of philosophy, not to bore you, but Schopenhauer said, all truths pass through three stages. First, it is ridiculed. Second, it is violently opposed. And third, it is accepted as being self-evident. That's just what happened to my monitor. And people would look at it and say, well, yeah, that sort of makes sense. You're going to monitor things, but nobody said that before. My analogy, Maxwell, is how many zillions of years do we have wheels? But how long did we go for without wheels on garbage cans or wheels on luggage carriers? It's like an epiphany. But as soon as you show somebody the idea, they go, oh, yeah, I understand that. I could have done that. But you didn't.
Mm-hmm. No,
you didn't really think it through. And on the slight chance you did, you neglected it and you didn't do the hard work. That's the answer to your question.
No, I think that's so true. In my field of interventional radiology, and I mean, you probably saw this somewhat peripherally, is, in like the 80s and 90s, and, radiologists were coming up with endovascular therapy, and the surgeons balked at it, the vascular surgeons and cardiothoracic, and they said, oh, this isn't the way, you got to actually, fix it yourself, fix it with your hands. And now, ironically, they've tried to take, they've taken many, adopted those techniques. And now, most vascular surgeons are trained both open and endovascularly. It's become in many ways the standard of care for, peripheral arterial disease. So it's, you see these things in medicine all the time where it's so, obstructed at first, but then people, when people actually give it a chance, it's pretty cool to see it actually become, it's how we move forward. It's unfortunately medicine is it's so stuck in its ways, I think, so time. And you obviously, that better than anybody.
Well, one of my heroes was Dr. William House from the House Ear Institute. He pushed hard on cochlear implants. One of the most famous neurophysiologists from where I was at Kresge Hearing Research Institute at University of Michigan got up at a meeting saying, look, there's 50,000 nerve fibers. There's no way a cochlear implant can possibly work. Stop subjecting people to torture. But the neurophysiology didn't pan out. It turns out all you need is a couple channels, or 4, or 8, and it got better and better. Bill House also was one of the first to use microscopes for surgery. He was totally panned until one neurosurgeon watched over his shoulder doing microsurgery of the ear, said, and then that neurosurgeon started using it for brain surgery. In fact, how about cautery? Hemostasis was a huge problem. This is why surgeons used to try to operate so fast, keep on going until the patient bleeds to death. Cautery was a great idea to stop bleeding. Surgeons said, this is terrible. It's taking away the skill of surgery, on and on and on. So, and Bill House, somebody wrote a book about him, and the book was The Unreasonable Man. George Bernard Shaw said, the normal person sees how the world is and adapts themselves to it. The unreasonable person says, no, I'm going to make it different and better. So all depends on the unreasonable man. But it's not easy being an unreasonable man. After innovation for William House, he was eventually estranged from the institute that he started, and he died unhappy. So fortunately, I've had enough hits as well as outs, and I've got the perspective to say, what I've done is good. I wish there was more, but that just isn't the way it's going to be.
Sure. One thing I wanted to ask you about too, because I mentioned it in our introduction for you, is your innovations in patient safety. I mean, which obviously are, critical for delivering, high quality care. It's, sure, we can invent, really technically savvy devices, but oftentimes things that make, like you said, washing hands, sometimes the simplest safety measures can really make a huge difference. Maybe tell us a little bit about that and those experiences as well.
Thank you. Well, so I told you about being a med student. So after years of graduation, a couple years of general surgery, 4 years of otolaryngology, the 7th years of microsurgery and skull base, I'm finally an attending staff. And I'm going, yes. So now I can saunter in for my first operation. I walk in, patient's anesthetized. The senior resident is prepping the left scalp. I walk in, I say, left scalp. He goes, left scalp, Dr. Kartush. I open the chart. I go, Jesus, stop. It's the right. And it's the nicest, smartest resident. And I go, God, if even this guy can make this mistake. So we didn't operate on the wrong side. We then shaved the other side. The operation went fine. But in recovery room, I was honest. I met with the patient husband. I said, look, we almost operated on the wrong side. But we didn't because we were careful. But reluctantly, you're going to look like Cyndi Lauper because you've got hair shaves on both sides. She didn't take it as funny. Now, fortunately, the results of the surgery were perfect, so there's no litigation. But I said, Lord, I mean, if I can make this mistake, if students and residents can make a mistake, what if? It's always my what if. What if we set up a new protocol? This is 1984. In which the surgeon walks into the preoperative area and says, Maxwell, which side are we operating on? Now, when I first did this, well, what do you mean, Kartush? You don't know? I said, I know, but we're double checking. I've got the consent form in my hand. Well, we're operating on the right. I said, your consent form says right? Good. And I would put my initials, JK, whether I was operating on the ear or the skull base or the neck. And at first I was ridiculed. And after a while, the preoperative nurses said, oh, I don't see a JK in the ear, so I know Dr. Kartush hasn't been in to see you yet. So the nurses started buying in. Then I said, we need a checklist because I can screw up. So we put a marker board in the operating room, and it had a checklist: patient name, allergy, surgeon, circulating nurse, and the resident all had to independently check what I marked, the consent form, and my office note. And the surgery didn't start until it was done. That started becoming routine. I met with the chief of surgery. Everybody ought to be doing this. And what I found, Maxwell, is that, first of all, nobody wants to talk about litigation, but especially when it's gross malpractice, it's the last thing you want to do. So it turns out I have to do some digging through physician-owned liability companies that when you had a gross incompetence of operating on the other side, the deal was, we'll give you $1 million, but there's a non-disclosure. If you talk about it, you don't get the money. So because of it, it seemed like there were few incorrect operations, absolutely untrue. Amputating the wrong leg, amputating the wrong breast for mastectomy. At one of the hospitals when I left University of Michigan, I said, look, you need to start doing this. Well, they're going to think we're stupid. We're not paying attention. 2 weeks later, a patient comes in for a left cerebral aneurysm and they're operated on the right side. Not until then did the hospital start to implement my protocol. And not until 10 to 20 years later did the Joint Commission and the World Health Organization implement these things.
That's amazing.
So
I mean,
I couldn't patent it. I've never been famous for it. The American Academy of Otolaryngology 10 years ago wrote a tribute article saying Kartush has done all this stuff and we should have been paying attention earlier. So it's one of those, well, I told you so, but how ridiculous that people couldn't do things that cost no money to do because of being stubborn.
no, it's so true. And I mean, people always reference the airline industry with those types of, safety checklists as well. And I mean, again, it's one of those things. Every single surgical procedure that's done, in IR, we do it every single case. I mean, it's something that's, it's like second nature now. It's not, people, you don't even, if you were to say, oh, let's not do it, I mean, you'd probably be penalized. I mean, because it's become where it's a liability if you didn't do it.
Correct. So it does show how things can change. And once it's there, oh, it's obvious. Of course, we need wheels on garbage cans. Of course, we need wheels on luggage. Of course, we should do this. But the day before someone suggests it, so crazy. So now, sort of skipping through, so patient safety, and I really looked at nerve monitoring as a means of patient safety. In fact, when I started the American Society of Neurophysiologic Monitoring, the Kartush stimulating dissectors were being advertised and sold around the world. Spine surgeons were mostly doing SEP, somatosensory evoked potential, and motor evoked potential. But those things are mostly to monitor the spinal cord and mostly for complex cases such as scoliosis. But as instrumentation came in, pedicle screws came in, such as our friend Dr. Michelson. Well, now you have to worry about, is the pedicle screw getting too close to the spinal cord or to the root? So I said, look, I've been talking about Kartush stimulating instruments for years. You should be stimulating your drills and your pedicles. The first article that came out by Calancy came out 10 years, never made any attribution, but then pedicle screw stimulation, has become the norm. So that's something that after a while you start realizing attribution is great, but as long as things are going to be changed and some things are positive, that's life in the big city.
Sure.
So then scooting forward just really quickly, I've had tons of other inventions. Reconstructing middle ears for hearing loss has usually been a 70 to 85% success rate. So I designed prostheses made out of hydroxyapatite to rebuild the incus and the stapes bone, titanium prostheses that look like a shepherd crook for stapes surgery. There's different ways to reconstruct perforated eardrums. So I designed an over-under tympanoplasty. And then for some little kids or elderly, taking them to the operating room for tympanoplasty really isn't the best result. So what ear surgeons would sometimes do is in the office, they'd see a little hole, they'd cut a little piece of cigarette paper, put a little antibiotic ointment on it, and try to stick it on the hole. And then the patient says, wow, that sounds better. For about 24 hours. Then when they cough or yawn or sneeze, the paper patch is gone. So my idea was to take a flange of silicone, another flange of silicone, and connect them between the two and pop it in like a myringotomy tube. So you can do that in 4 minutes in the office. So those were the Kartush patchers. So there's a whole slew of those types of things. But then moving on, there were some things that I let go. So So I started getting recruited to Stanford Institute. And being a guitar player, I always thought about going out and playing music with California girls on the beach. So I said, I'm out of Michigan. So my wife and I went out to Palo Alto, and I loved it. But it turns out the cost of living then was high, and an academician's salary was low. So I said, I'm not sure if I can afford to be out here. So if you've ever heard of Dave Packard,
Sure.
Hewlett Packard.
Sure.
So
Sure.
somehow he heard that this Kartush guy is interesting. So Dave Packard said, Jack, I got a way to get you to Palo Alto and afford it. So I signed a non-disclosure form, and I went into the secret lab that was run by DARPA, which is the Defense Association, basically by the Army for projects. In fact, there wouldn't be quadcopters and drones if it wasn't for DARPA. So DARPA was working with SRI, which was the Stanford Research Institute. Signed the NDA, and I come in, and based on my loves, it's like, oh my God, it's like a video game. This is amazing. It was the first prototype of a surgical robot.
Wow.
So the idea from the Army is that a soldier takes a bullet to his gut, he's down, the medic puts on the surgical robot lying on the field, and the surgeon is 3 miles away doing remote surgery.
Wow.
So it sounded like a cool idea. So, but lo and behold, my wife said she didn't want to leave family in Motown. So that's life in the big city. Life is an odyssey. And if you look at A Wonderful Life, you see the end of the movie and it's Christmas and everyone's happy. But you know what? The odyssey was getting there, and he went through hell and misery. And so there's been a lot of good things. There's been a lot of bad things. So, but there's happy endings, and then there's normal endings. So it's something that you don't talk about. But as you and I talked about, Maxwell, I'm on home hospice right now. My hospice nurse is not happy with me doing all this type of podcasts and lecturing, but I have two things left for my bucket list. And one is to upload a lot of my teaching videos to YouTube. So for those that are interested, if you go to YouTube and put in Jack Kartush, you'll be able to see some of my videos on teaching in medicine and in rock and roll.
We can link to those in the description too. We'll provide the listeners with the link so they can click right to it.
That would be great.
Yeah.
And although I stopped working with Medtronic years ago, there were some issues with the Medtronic nerve monitor. So after all these years, I'm back to being a consultant for Medtronic. So that's bucket list number one. Bucket list number two is I never gave up on music. So my friend, his wife has cancer, and he remembered her being young, driving in a Jeep with her hair flying through the wind near a beach. And he wrote it as a poem. And I said, this would be a great song. So I wrote the music, and the song is alternatively called Jeep, or She's Got a Jeep. We were hoping that it would become a soundtrack, just like we did for Fox TV, for a Jeep commercial. So if there's any Jeep people watching out there, see if you can get this song. We did one version that I produced in Nashville at one of the top recording studios, Baird. One of the singers we used is Adam Cunningham. He's a finalist for The Voice. Another is Matt Dame. We did a country version and a rock version.
You can hear the country version of Jeep on Apple Music under the throwaway name of Lloyd Blitz. And if you want to hear a fabulous YouTube cover band, check out First to 11.
That's got 2 million followers, and many of their songs have 10 to 20 to 30 million hits. So I'm also looking at producing it with the young band to be able to hit a younger demographic. So those are my last two bucket lists there, to get my information so that it's memorialized, so that people will be able to use it when I'm gone, and maybe to be able to get one more soundtrack that's out there. And again, I'll finish by, what I may have said before is, the enemy of good is not better. It is the relentless pursuit of perfection. You never get to perfection, but it is the pursuit that gets you better and better.
That's amazing, Dr. Kartush. I mean, it's you certainly had a remarkable life. I think I think you could look back and feel certainly a sense of extreme accomplishment. So, and I think what's so fascinating is not just, obviously you were practicing this whole time. I think people, just so people realize, I mean, you were still a fully practicing physician doing surgery. I mean, I think from what you've told me, you were one of the highest volume surgeons in your field, and then also producing devices, and then also just, this success in music as well. I think something totally outside of medicine. I think that's so interesting. I'm curious on that note, are there any, I always try to ask guests outside of, obviously you had a, lifelong passion for music. Any other ways you help balance, this very busy career you've had?
Yeah, I don't sleep. That's been a good thing. And usually when I'm hot on something, if it's 1 a.m., 2 a.m., 3 a.m., I just can't stop. So I've probably been chronically sleep deprived for most of my life. But to me, I don't know, it was sort of a balancing act. And I would just get so much internal dopamine that I just wouldn't want to turn it off. And so I think that's been a helpful thing. And of course, I've got a great family. I've got some great grandkids. And I think it'll be interesting to see, what route they take, whether it's rock and roll or surgery or something else.
That's amazing. Well, Dr. Kartush, thank you so much for taking this time. I really enjoyed this conversation and hearing, really about all the different, the path you've taken in medicine and surgery and devices, and really learning about your process, and certainly all the lessons you've accumulated along the way. It's been really a great education. And really, like I said in the beginning, it's a true honor to talk with you and learn more about medical device development, and just even just the pursuit of, not being afraid to really take that leap and pursue what you really are passionate about, and really, what your new ideas are, new innovations, and really how to make a difference. I mean, you're someone who's, you didn't just do it once, you did it many times over. So thank you again. Really, really means a lot. Appreciate it.
Maxwell Edison Cooper, you got a long way to go in your career, and I'm looking forward to seeing what happens. Thanks for your time.
Thank you.